Our webinar today will discuss the latest innovations in surgically treating brain tumors. My name is Joanne Demas. I'm the Senior Program Manager here at the American Brain Tumor Association, and I am delighted to introduce our speaker today, Dr. Julian Bales. Dr. Bales is Surgical Director of North Shore Neurological Institute and Chairman of North Shore Department of Neurosurgery. Dr. Bales is known for conducting leading-edge clinical trials, including exploring the effectiveness of using fluorescent dye in the resection of tumors. Thank you so much for joining us, Dr. Bales. You may now begin your presentation.
Thank you, Julianne. It's great to be here with everyone and to tell you a few of the advances that I'm aware of and what we're involved with. I am a clinical professor of neurosurgery at the University of Chicago Pritzker School of Medicine and the surgical director of the North Shore Neurological Institute. We're based in Evanston, Illinois, and part of the North Shore University Healthcare System. So there have been many changes and many advances. However, brain tumors in particular remain a very challenging problem for the doctors and the nurses and the hospitals, and particularly the patients and their families in dealing with them. So I thought I would give sort of an overview of some of the, what I believe are the innovative changes and innovative techniques that have evolved, and not certainly just by us, but by many investigators, many developers around the country and the world. So I'm going to talk and focus really on four major advances which come to play on many, not all, brain tumors, but have a role to play and are really, I think, cutting edge for the most part, and I'll try to demonstrate that today. These are the four: visual ACE, Nico, stereotactic radiosurgery, and then a fluorescent dye clinical trial that we're involved in. We look at really for who's a candidate for new treatment, and I guess that many, if not most, patients are potentially candidates for new treatments, and that really involves location. It involves the age of the patient, the type of tumor, what part of the brain is affected by it, and to what extent. I'll talk about a few case studies and a little bit more about the future innovation, and then at the end, after I talk for 25 minutes or so, we'll have a chance for some Q&A. You know, every year there are nearly 500,000 brain tumors newly diagnosed in the United States, so that's not a small number, of course. They are almost always problematic and not good things to have and need to be dealt with, and most of the time need to be treated and or removed so that you're done with them. The categories really are considered as primary brain tumors, meaning the ones that originate in the brain, and they're composed of brain tissue, brain cells. The most common is one called glioblastoma multiforme, and that's a very malignant tumor that is very problematic and has to be almost always operated on and treated aggressively. If so, there are some new advances in the treatment, and you'll see some of that today in my talk. But they are the #1 primary brain tumor that we deal with. There are others, and it depends on the age group, what type. And there are some that are not malignant, but that is the one that we'll really center on today for most of these advances. Now, there are also metastatic tumors, meaning it's cancer somewhere else in the body which is metastasized or traveled to the brain. Probably 20–25% of the new brain tumors we see are metastatic, and they also can be dealt with effectively. Most of the time are best removed and not left in. But they also have taken advantage of some of the new techniques. The other things, which is not technically a tumor, but sometimes we treat sort of like a tumor, is a hemorrhage, a hematoma within the deep part of the brain white matter, and sometimes now with new innovative techniques, particularly the ability to put a neuroport in there, we're able to remove a clot using a Nico type device, which I'll demonstrate. Brain tumors are complex. They're not always operable, but they should be each and individually considered. We really feel very compelled to continue to make innovation. In the last 30 years, has seen a progressive increase in the oncology side, chemotherapy, radiation oncology, but also the surgical side. We probably still operate on a fraction and not the vast majority of tumors. Many or some are not considered to be operable, and so in some cases open surgery has its limitations. Innovative treatments really is revolutionizing through new technology how we can treat them, and we like to think of innovation as having several characteristics, and certainly first and foremost is that they're usually minimally invasive, meaning minimally disruptive to normal brain tissue, and safe and effective. And that could offer promising outcomes for ones that in the past were considered inoperable or difficult, hard to reach tumors. These four innovative treatments I'm going to detail in the subsequent slides, and I will talk more about their particular role and what I see them in the entire spectrum of treatment. The first is the fact that lasers ever since the 1980s have been of great allure to us in brain surgery because of their precision, their precise delivery of destructive energy to a point that if safely applied and safely navigated in, this energy can really be harnessed to help a patient. There are a couple ways to do this. The one that we've had the experience with is one called visual ACE, and that's a fiber which is directed stereotactically or by navigation into a certain part of the brain. It's a very small fiber that through it the laser energy is delivered. It's put in through just a very small opening, the size of perhaps a cocktail straw, and through the scalp it is placed. There's a tiny hole placed in the skull, and the catheter delivered into the lesion or the tumor. And we do this under MRI guidance, so we're watching the placement of the catheter. A 4-millimeter incision in the scalp is made, a 3-millimeter drill hole is placed, and a 980 nanometer diode laser is placed under MRI guidance, especially important for difficult and high-risk tumors. You see in the slide here, this case study is a 54-year-old with a lung tumor which has metastasized or traveled to the cerebellum part of the brain. It is not a real big tumor, but it is in a critical location. It is deep in the brain, as can be appreciated here. And you see the laser fiber there with the yellow arrow delineating it right to the target, to the tumor. And you can see how this is very precise and very much minimized in order to deliver destructive energy to that target. And you see here on this slide, this is a thermal map during the treatment, and that's how we monitor it real time while the patient has the treatment inside the MRI. This is something that just a few years ago would have been considered very futuristic, and something that really has great allure to us because of the potential for, without formally opening the head, placing a destructive laser beam right into the target and watching it occur during an MRI is extremely valuable, we think. You see here the treatment time is extremely short. This patient had 4.2 watts of energy for 28 seconds and 10 watts for 207 seconds. So a total treatment time of less than 5 minutes for this particular tumor. You can see in the thermal map as the heat of the energy from the laser spreads, we can watch it coincide and overlap the area of the tumor. Prior to placing it, we do a pre-ablation or pre-treatment MRI. We do models of the type of energy we want to put in, and we can predict the damage done by the wattage and the time of laser application. This shows following ablation. You see the tumor, the lesion here, but you can see serially with time the tumor changing and undergoing its death cycle as it reacts and sort of dries up from the effects of the laser treatment. The advantages is that the procedure can be performed with the patient awake. It's minimally invasive. Instead of having a craniotomy or formal brain surgery, there's just a very small opening created. It requires only one stitch to close the surgical site. There's minimal pain, minimal discomfort. Most patients do not have to go to intensive care. They have a rapid recovery. They normally just stay in the hospital overnight. And they don't even have to have their head shaved or any significant alteration in their appearance or status. The next big advancement, and something that I'm personally very excited about, is the Nico brain path procedure. And this is a way to utilize modern technology and bring that to bear on treating tumors that are below the surface of the brain, as most of them are. And the Nico brain path really utilizes the 6 pillars of the principles of their treatment. And I will take you through the individual pillars. This is the most exciting thing to come across in brain surgery in my career for lesions located deep within the brain or anywhere under the surface. The first pillar is really based on navigation, based on the anatomy of the brain. So you see here, this is fiber tracking, which are images which are obtained prior to surgery. And in the first pillar, you see that the area of approach perhaps would be right here where there are fewer fibers. These are all the fibers of this side of the brain, this hemisphere, all being funneled down to enter the midbrain and brainstem and ultimately go to the spinal cord. If there's a lesion here, this would be the obvious place to approach because through this corridor here, there appears to be very few fibers. So this is an example of having more intelligence, more upfront knowledge of the anatomy of that patient, and being able to base what we do not on standard textbook pictures, but on that particular patient, on fiber tracking, so we know where the major bundles that connect the different parts of the brain or the brain with the body are located. The second pillar of the brain path procedure is navigation, and what that means is this is sort of like a GPS system that you have in your car, and this shows us exactly where we are. We navigate the insertion of the instruments or of the port. That provides us with precision and absolute accuracy of where we are located, again allowing us to minimize our opening. The third pillar is special optics, optics which continue to evolve and get better. This is not a surgical microscope, but it is an endoscope placed on the outside with this special arm, and there are new robotic applications that we think are going to make this even more attractive and facile in our use. But this is our optics, which really give us superior view inside the brain of the location where we are working. The fourth pillar, and really sort of the cornerstone of the Nico brain path, is this port, this 13 millimeter port, which is about the size of a dime, which is placed and through which we can operate. And through that port is where we gain access deep in the brain. We place that port navigated based on preoperative white matter tracking to know where all the critical fiber bundles are. And then we begin the fifth pillar, which is resection, with this special device called a myriad, which allows us to resect, remove the tumor, and then it saves the tumor in a special trap, tissue trap, like a test tube, that allows us to then apply in the future the sixth pillar, which is therapy based at specific cell types, specific characteristics of those tumor cells. And for the first time, really, instead of discarding tumor tissue, we're saving it, we're collecting it, we're banking it to apply the sixth pillar in the future. This is a very advanced procedure and technology, which really, I think, better than ever gives us hope to treat subcortical and deep brain lesions. Here's an example of the surgeon operating, and you see me sitting there, and you see the ectoscope here, and that's the optics. We're looking at it on the television screen here. The patient is in this position here, and here's the opening, and we're about to approach and open and gain access to this deep tumor. We also use so-called real-time imaging, which is in this case an ultrasound, which allows us instantaneously to see through sound waves, as you see right here, the tumor, and to know where we are and where the lesion is, and again to minimize and to increase the effectiveness of our procedure. So in summary then, the Nico brain path provides us with 6 pillars of treatment, which is white matter mapping, navigation or GPS, so we know where we are, superior optics for a better view of our subject and of the lesion in question. Here you see an example of that. Here's a large tumor. The green are motor fibers, motor control fibers. The beige circles here represent speech fibers. And you can see how when we're navigated, the crosshairs tell us where we're pointed, where we're going. You see in this view here the motor fibers all behind the lesion, behind the tumor. The last 3 pillars involve access through the small port, superior resection devices to allow us to go in and actually remove the tissue safely and effectively and precisely, and then finally to save the tissue for specific therapy. Here's an example of a case where here's the MRI, the preoperative MRI in the background, and here's the ultrasound real time while we're operating. And you see here the lesion, the tumor, and you see it nicely matching up from the preoperative MRI to the intraoperative real-time view here, showing the surgeon exactly where we were and how much progress we're making as we're going down through this tumor. Here's an intraoperative view. We do a very minimal approach, so we don't shave the patient's head. There's a little small amount here, 1 inch shave, and then you see the incisions about 2.5 inches. Once we open the scalp, you can see the planning here being done. Here's the circle outlining the area of bone or skull, which is temporarily removed. And here you see the port being navigated through these 5 spheres communicate with a camera system in the ceiling of the operating room, and that's our GPS. That tells us our trajectory, our distance to our target. And you see in the real-time ultrasound, you see areas of tumor resection. You see how we can monitor that as we go. This slide shows the monitor, the surgeon's view inside the operating room, and here's the opening of the dura, and there's the brain where we're going to insert the small dime-sized port. When there are lesions that we can't take out, we can't resect, there are advances in radiation therapy that sometimes are extremely effective. We look at radiosurgery as being an application of destructive radiation ions to an area that needs to be destroyed, and once targeted and once calculated and applied, there are potent doses of radiation that will melt away tumors or stop tumors from further growth that are applied, again, in a minimally invasive way. There are various forms of radiosurgery applications. This is showing the gamma knife, which is a popular technique using 201 sources of cobalt that are focused down through various apertures, and individually these beams of cobalt are not destructive, but the point at which they all come together is an area that a lesion is created or something is destroyed. And there are various ways to do radiosurgery. It can be gamma knife, it can be a cyber knife, it can be a LINAC-based system. They all accomplish the same basic principle, and that is to focus radiation to destroy a lesion. And that's where the word radiosurgery comes from. It's not really open surgery, but it's done with the skull closed. It's done often as an outpatient. But for many patients, it's a very attractive and has been a very successful treatment to either destroy or to stop a tumor from further growth. Many patients who, for various reasons, are too sick to undergo surgery, the tumors are deemed to be inoperable, or not really capable of being cut out or resected with open surgery, or if there's a risk of harming critical structures near the tumor. These are all indications for any one of the several types of radiosurgery which I mentioned. Now, radiosurgery is not able to be applied to large tumors. Generally, about 2.5 to 3 centimeters are the sizes of the tumors that we treat, so about an inch or maybe a little bit bigger. Sometimes the tumor is just too big and it's causing too much mass effect, too much swelling, too much pressure inside the head, and in that case, radiosurgery is not appropriate and is not done. But for certain patients, depending on size, location, type of tumor, their overall health, radiosurgery is a very viable option, and one that you should know about in considering your possibilities for tumor treatment. The radiation high energy beams match the confines and the configuration of the tumor, even if they're irregularly shaped. Usually it can be, a treatment plan can be constructed such that the tumor is destroyed and to minimize damage to the surrounding normal tissues. Other advantages are that it is virtually painless. It's done as an outpatient. It occurs as a single day treatment. And it's minimally invasive. The cranium is not opened up surgically. There's no incision. There's no scars. So stereotactic radiosurgery is a very important option to know about, to consider, but not suitable for many tumors. We're very excited about the clinical trial that we have here in North Shore, and that is using a yellow 560 dye. And what this does is that the dye is injected intravenously while the patient's asleep and while we're taking out the tumor. And what the dye does, we believe it accumulates in the cancerous cells, so it turns any cancerous cells to a fluorescent yellow. It's like the same phenomenon of a firefly fluorescing. And we have to operate as we live in our world of white light. We base on white light. But if we can get an advantage, if we can get benefit for the patient by the fact that cancer cells are going to reveal themselves by taking up this yellow dye and fluorescing, that's a tremendous potential advantage for the surgeon and for the patient, for him to be able to visualize which cells are bad, which ones are cancerous. So the use of a yellow fluorescent dye is very exciting. There are a few centers around the country which are using it. We're proud to be one of them, and I think the jury is still out. In general, experts have felt that it does increase the ability to see, visualize, and remove remaining cancer cells. And so this is a perfect example of new technology, high technology that we didn't have in the recent past, and one that we have to figure out its ultimate role in resection or removal of tumors. It is removed, it is used in conjunction with a specialized microscope that has a specialized filter that allows the surgeon then to see this fluorescence. And right now it's used for removal of glioblastoma, the highly malignant primary brain tumor. The purpose of our study here is to assess whether this used in combination with this special microscope will allow us to resect more and do a better job of removing, and to really work on that important issue called extent of resection. In other words, how much of the tumor the surgeon was able to remove. Not all patients with brain tumors, of course, are candidates for these new treatments or others that you may hear about. The treatment depends on many, many factors: the age of the patient, the symptoms of the patient, the diagnosis, the size of the tumor, what we think it is, what kind of tumor, its location, its configuration, and then, of course, the treatment preference by the patient also plays in. And does the patient not want their head open? Do they want, at any cost, the procedure to be minimally invasive? And that's one that's done, taken in consultation with radiation oncologists and neuro-oncologists and neurosurgeons, all putting their heads together to come up with the best recommended treatment. We can just imagine the operating room of the future will entail many of these technologies that I have shown today. And there are others, and we're very excited and we're privileged to be a part of the wave of new technology that's hopefully going to make progress in treatment of brain tumors a further reality. Patients are already living longer and doing better. We need to do our part as surgeons to minimize the invasiveness, increase the effectiveness and the precision of removal of these tumors, and we do that by applying all of these technologies to the point of care, to where the patient needs it. No doubt there will be many bright men and women who are going to continue to make advances in our treatment abilities for these patients. But right now we can see how the operating room of the future is going to really become more and more high-tech, and it will have tools that enable the surgeon to see what he right now can't see, to gain access to where he can't go, and once he gets there, to be able to more effectively and precisely remove the unwanted and the bad tumors. Thank you for your attention. It was a pleasure to present to you some of the things which I think are important and breaking in this area. And I think we have time for a Q&A if there are any questions. Thank you.
Thank you so much, Dr. Bales. We definitely do have several questions. And just a reminder, if you have a question you'd like to ask, please type it using the question box in the webinar control panel on the right-hand side of your screen. But we'll start with some of the ones that have been coming in. Is it possible to successfully use radiosurgery on a low-grade spinal lesion? And if so, are there any risks to the spine?
Yes, in certain cases, I think that radiosurgery has been effectively used for spinal tumors, particularly the ones that are not malignant. There have been not too many, but some centers around the country that have had experience. And if a patient is interested in that, I would urge them to seek out one in their area, in their locale, who've had experience. But the answer is yes, it can be very effective, I think.
Perfect. You mentioned during the Nico path, I'm reading this question, sorry. What method does the Nico path use to save the tissue during the fifth portion of the Nico path?
Well, in the Nico procedure, the resection device has a very innovative aspect, and that is instead of the tumor just going down the drain or being discarded, it's collected in a special trap. It looks kind of like a test tube with a screen in it, and that collects all the tissue, and that is then sent to the pathology department where it can be tested and analyzed and saved. So it's very innovative in the concept of not removing and discarding tissue, but saving it. But there could be some application 5-10 years from now that we haven't even thought of presently, that tissue could be extremely valuable to have.
So it's preserved in wax, or?
Well, it's preserved. It's caught in a trap, and
Okay.
it's sent to the pathology department, and then they will preserve it any number of ways, freezing it or
Okay.
placing it in formalin or cutting it on slides and mounting it. So they have a variety of ways that they would process it.
Okay. And then the same person has a follow-up question. What would the tissue then be used in 5 or 10 years? Would that be for their recurrence, I'm assuming?
Yes, probably. Probably.
Okay. So I guess then a patient needs to be really informed going into this and talk to their surgeon about their options beforehand, knowing what questions to ask and knowing what's available to them, right?
Absolutely. This should be on the list of questions to ask your surgeon. What happens to the tissue that's removed, and is it saved, and could it one day be of good use for me or any other patient?
Yeah. All right. Here's another question, wanting to know if these treatments can be used on brainstem tumors.
Yes, in some cases, depending on the tumor and the location and so forth, it can be. So, again, every case has to really be individualized, but some of them can be, yes.
Okay. We'll combine two questions here. One person is asking about if it's ever possible to remove 100% of GBM, and someone is talking about a Dr. Bukovar who said that they fully resected 100% of a GBM patient using direct infusion. So Do you think it's possible, and have you heard of this doctor using this type of method to remove 100%?
No, I'm not familiar with his work removing 100% of gliomas. And in general, we think it is probably technically impossible to remove 100% of a glioblastoma because of what we call the microscopic disease. So it's certainly possible to get everything out that can be seen either with the eye or even on an MRI scan. But we worry that there is leftover residual tissue that just can't be seen with any current technology, and that's the microscopic disease, and that's probably why these tumors, for the most part, are at the end of the day, not curable. We talk about living with the disease and prolonging survival and progression-free survival and quality of outcome. All of these are the measures that we talk about, the terms that we use. But glioblastoma is not 100% removable, I think, by anyone.
Yeah, I would love for that language to change someday, as I'm sure we all will, but we're doing the best we can until then. Someone's asking about, again, kind of two-pronged. They're asking about seizure-free with any of these type of procedures, and also a procedure that goes in through the cheek that would cause someone to then be seizure-free. So would any of the methods you talked about help someone be seizure-free? And have you heard of another method of surgery that would go in through the cheek to help someone be seizure-free?
Yeah, I've heard of the latter. I've never performed it myself, but in general, I think the way you think about it is that to remove an offending mass, a mass that's creating pressure or pushing on something in the brain or irritating, to remove it is the best way to try to prevent seizures, and normally it does. But there's no guarantee. You can even remove a tumor completely and the patient could still have seizures because that part of the brain has already been irritated. So that's about the best you can do. Normally it helps, and on the other hand, there's no guarantee that a person would never have another seizure.
Right. It's always a good conversation for individuals to talk with their doctors or their nurses. I know that we experience that a lot with people calling here and talking to our nurse. Seizures are about medical management too, and finding the right drug or the right dose, and we encourage people not to give up because there's always seems to be another drug out there for a seizure. So, you don't have to always suffer through living with one drug if it's not working for you. So here's a really good question, and you may not experience it working, where you work, and we're blessed living in Chicago. But the phone calls we get here at ABTA, this question says it all. They're writing from semi-rural region of Canada. What about those people that are calling from the community hospitals and they don't have the option of all the choices that you would have at a North Shore, that you would even have at all the choices that we have in Chicago? What would you tell the patient that has only a community hospital to go to and had a brain tumor diagnosis? How would you lead them into making choices?
Well, that is a good question, Jillian. I guess the answer is I don't know for sure, other than I think that if someone is at a rural setting and they can't, for whatever reason, be transferred to a bigger center that may have some of these new technologies, I think they need to talk to their surgeon about what he knows about emerging technologies, and I think in general they need to insist on having something removed if it's deemed at all possible and safe to do it. I think in general they shouldn't allow, just because they're in a certain setting, to dictate less than an aggressive approach. I realize that's easier said than done, but I think in general, no matter where you are, you want to push to have things removed surgically from the brain so that treatment can begin if anything is left behind.
And I think we could also encourage them to send their medical records to a place that has a tumor board and, see what their recommendation is. And we can always walk them through that process if they don't have that luxury of that multidisciplinary team that, the hospitals in a major metropolitan area does. And, we're always happy to do that and walk them through the process. Next question.
Absolutely, and if they want to send the records or inquiry to me, I would be glad to review it for them.
Wonderful. Thank you. Someone's asking what the difference is between Visualase and NeuroAblate, and is one better than the other for a deeper tumor?
I've only had an experience with Visualase, and I think there have through the years been different sorts of laser, different energy sources, and different ways to skin a cat, and those are two different types of laser technology, and so I can't comment on any one except the one that I've used, and I think it's safe and effective. I think there are maybe about 700 patients who have been treated with Visualase thus far. So I think the principles are pretty much the same. It's just how you do it, what tool you use, but I think the principle is the same, and that is using laser energy to ablate or irreversibly damage abnormal tissues. So I think they're pretty much the same in that regard.
With some of these, do you see a lesser amount of cognitive changes than you do with other types of surgery, or is there still the need to follow up with neuropsychology?
I think that most surgery is safe. I think it's safe from a neurocognitive point of view, and depending on, again, where the tumor is located and what it is, may dictate a big part of that. But I think in general, all these procedures I've described are effective and safe and preserve the neurocognitive function.
Great. Someone's asking about super selective intrusion therapy of Tumor directly into the tumor site, wanting to know your feelings or concerns about that.
I've had no personal experience with that. We have, through the years, tried super selection for various aspects of trying to deliver treatment just to a certain area so that the whole brain is not exposed to it. So brachytherapy, inserting radioactive radiation sources right in the area of a tumor. There's chemotherapy wafers called Gliadel, which have been used, which is sort of another form of local infusion by placing these wafers directly on an area of tumor or tumor bed. So these are all examples. I have not had any experience with a selective injection of Timidor, but again, I think that none of these have been proven to be vastly superior or to have made any significant differences in the outcome, but they all should be encouraged to continue to be explored.
Agreed that there's so many choices out there that, making sure the patient and the family are educated is really, really important. So they're making the best choices, and I realize that a lot of times they're diagnosed so quickly and taken to surgery that there's not a lot of time. But when there is time, being able to call a resource, to toot our own horn, of course, to, call someone like ABTA and, talk over what your choices are, talk with your surgeon, talk with your nurse, learn as much as possible so you're making an educated choice, not a choice out of, fear. That's the best way to make a choice that's best for you as a patient and the family. So I completely agree that, you have to learn to make those best choices. Another question about ablation. I know, it's not something that is, right up your alley, but if you could answer, if you can't, that's fine. What are the cons of laser ablation? And they're asking about how they determine the pathology. So I'm assuming that do they do a pathology beforehand and then do the ablation? This person is wondering.
Well, there are different ways to do it. A lot of times these lesions are metastatic lesions, and the primary source is known, so it's a known lung or breast or other source. Sometimes a biopsy is performed first and then the laser is applied, so we kind of a 2 steps to one procedure. So there are different ways to do it. Sometimes it's a recurrent tumor. It's a tumor that's been biopsied and taken out and recurs. Sometimes it's radiation damage, radiation necrosis, so it's sort of presumptive diagnosis that we kind of know what's going on. So these are the different categories, the different ways that these are approached. There are 2 main lasers we mentioned that are in use now. Maybe on the horizon in the future we'll have different and even better laser technologies.
Again, I like the way that you think that, we'll have a webinar like this in the future and there'll be more things and better options, and, that's always our hope for our patients, that we'll continue to create new things and new tools and new techniques, which brings me probably to our last question. For the meningioma patient or, the other benign patients, the ones that seem to sometimes get forgotten, they live with watching and waiting and then sometimes need surgery. Do you see, are any of these options available for a meningioma patient? Or are these specifically for, those patients who are dealing with malignant type tumors?
No, that's a good point. We were sort of picking on the malignant tumors, but benign tumors like meningiomas can be just as problematic in some ways, and depending on their location, size, etc. So a lot of these techniques really, I guess everything I showed could be applied as well to benign tumors such as meningiomas. Maybe not the yellow dye, but certainly the Nico neuropath, the brain path, the working through a port, the small opening, the minimally invasive style and philosophy, the visual ace. All these are things which can be applied to meningiomas as well in many cases.
Wonderful. Yeah, sometimes I feel like we leave them out of the picture, and I think it's important to always, you mentioned metastatic, and I think it's important to remember that, we cover, everyone, that it's not just the GBMs, that, of course, it's the metastatic, it's the cysts, it's the benign tumors, and, especially the benign tumors that live a long, healthy life, but then they need surgery. So knowing that, we're out there to assist meningioma patients as well. So thank you for that. That's a perfect question to kind of end the webinar on. I thank you for answering so many of our questions. We got through all of them, so that was wonderful. And I appreciate everyone for really coming up with some really great questions for us today. So I thank you for joining us, and thanks again to Dr. Bales. And for more information on any of these topics, please call our 800 number, which is our care line. It's 800-886-2282. We have publications on stereotactic radiosurgery. We'll have this website up, this webinar up on our website at Anytime Learning. Like I mentioned, you can call and talk to our nurse or our social workers. They'd be glad to walk you through questions to ask your doctor before any of your appointments. So we're just here to help however we can. So I'm going to pause for just a moment and conclude our webinar recording. Then I'll come back and tell you about 2 more exciting webinars we have coming up in the future. 1 second.